on this one, pay attention to our 5 objectives here. And we're really looking at the upper respiratory tract and diseases, and then the lower respiratory tract and diseases. Again, these medications, similar to what we had in our last chapter of chapter 36, we're not going to cure a disease with these. We're really just minimizing the symptoms that patients have with these diseases. A couple of key terms, and I don't think I had any outline because they're all important for this chapter. So if you scroll through these and make sure you understand the different key terms for here, we're basically looking at 2 distinct respiratory diseases, that of asthma and COPD. So there's quite a few of these that go along with asthma, and then some that go along with our COPD. Both of them have that underlying anatomy and physiology problem of bronchial constriction. So when I scroll down, if I'm looking at my overview, I want you to think about upper respiratory tract versus lower respiratory tract, and then how both of those play a role in oxygenation and what the importance of oxygenation is. And then when we're looking at some of our pathophysiology of the diseases, we're really going to play onto 2 of them. These seem to be the ones that you're going to see most likely in the clinical setting. Of asthma and COPD, a little bit about chronic bronchitis. But if you get the principle of asthma and COPD, you'll be able to pull out what's important with that chronic bronchitis. Well, we've done asthma in the classroom a little bit. We have talked a little bit about bronchial constriction with a lot of our medications. So with asthma, my patient's bronchial tree becomes very constricted, and they have an increase in inflammation and edema. So when we have that viscosity of mucus. So when you put all that together, think about that bronchial tree getting smaller in size, getting very edematous, and then having an increase of that really viscous, thick mucus, which obviously is going to make it more difficult to do that oxygen and carbon dioxide exchange. Your book goes into a little bit about the difference in the antigens and the allergies. Know that something usually triggers an asthma attack, and that's what tells the body to, I'm not happy. I'm going to do that bronchoconstriction and have that edema there. A few things that are mentioned here about different things that we use to treat our asthma attacks, and then some of the things that are the steps of an actual asthma attack. And then we're going to scroll down next to our COPD, so you understand that. On this one, you can describe it simply by reading the term of it. So the chronic, it's going to go on forever. It's not reversible. Once I have it, it's not going away. And then I have an obstruction. That obstruction is that narrowing of the bronchial tree. You'll notice that they have our terms over here, chronic bronchitis and emphysema, but we don't typically see that as much as we just use the overall blanket term of COPD. When I'm treating these are diseases of our lower respiratory tract. So when I treat these diseases, my first thing that we're going to look at are my bronchial dilators. And that makes sense because we mentioned with either our chronic obstructive pulmonary disease or my asthma that I have bronchial constriction, which makes it difficult to do that oxygen and carbon dioxide exchange. So my first thing I'm looking at are my bronchodilators, and it's doing exactly what it says. It's going to open up that bronchial tree. It's going to open that up so that we can have more oxygen, be able to exchange more oxygen. Here's some of our mechanisms that we'll use for those bronchial dilators. Does it good if you're a visual. You can see what's going on when we have a patient that has asthma or an allergic response, I guess I should say. And then it talks a little bit about the different actions on how they're dilating that bronchial tree. Let me scroll down a bit. We are, for our bronchodilators, we're going to look at 2 different ones here. My first one is my albuterol. On this one, it's it causes that bronchodilating effect, very effective for that, to keep that bronchial tree dilated and opened. Versus, let's see. I did want to note this. If it's used too frequently, I can see drug-related adverse effects, and it loses some of its efficacy So we want to make sure also that we note that it can cause some nausea, anxiety, palpitations, tremors, and increased heart rate. So note that with our albuterol versus salmeterol. On this one, it's more of a long-acting medication for the bronchial constriction. I think those are my two big things with that one. I do want to point out that with our salmeterol, that it is not to be used for an acute treatment. We use this one as a maintenance treatment for asthma and COPD, which means it needs to be taken on a regular basis. Traditionally, commonly we can also use this medication in conjunction with a corticosteroid. So think about if I'm giving a corticosteroid and a bronchodilator, I want to give that bronchodilator first so I can open up that bronchial tree and then use my corticosteroid so it can get down to the very ends of that bronchial tree and decrease that inflammation that's there. Usually, our salmeterol is used with other inhalers also. My next group of medications are my anticholinergics. On my anticholinergics, it's doing exactly what my anticholinergics have done previously. They're going to block that bronchial constriction and it's going to decrease some of those secretions. We're going to use this to prevent bronchospasms, usually that are associated with my COPD patients, and it's not used for acute symptoms. They're contraindicated if they have drug allergies or if my patient has an allergy to atropine. And some of my adverse effects with these medications is it can cause dry mouth or dry throat. It can cause some nasal congestion, heart palpitations, some GI distress, urinary retention, increased intraocular pressure, headache, coughing, and anxiety. My drug of choice for this one, Imatropam or Atroban. It's my very oldest anticholinergic bronchodilator, very similar to atropine. It can be given as a liquid aerosol for inhalation or as a multi-dose inhaler. It's to be dosed usually twice daily for those individuals. My xanthine derivatives are next. We have one xanthine derivatives here. They cause bronchodilation specifically. They're used with both my asthma and my COPD patient. They can be used in mild to moderate cases, and they can be used in adjunct treatment. Because there's a lot of drug interactions, it's not used as commonly as the previous two group of medications. They have a slow onset of action, which means it's not useful to treat an acute asthma attack. It's used to prevent those syndromes, not an acute asthma attack. It's contraindicated with drug allergies, uncontrolled cardiac dysrhythmias, seizure disorders, hyperthyroidism, and peptic ulcers. Lots of adverse effects to include anything from nausea, vomiting to cardiac effects such as sinus tachycardia, palpation, and even some ventricular dysrhythmias. It can cause a transient increase in urination and hyperglycemia, which is an important thing to note there. So checking blood sugar would be important. Overdose and other toxicity of xanthine derivatives are usually treated with repeated administration of activated charcoal to decrease that toxicity. On our xanthine derivatives, an increase in the serum level of other medications have been known. So keeping that in mind. Also, if we use them with other sympathomimetics such as caffeine, it can produce additive cardiac and CNS stimulation. So keep that in mind. Cigarette smoking also has a similar effect at the same time with that. Let's see. There are some foods that have that include charcoal, such as some proteins and carbohydrate food that reduce serum xanthine levels. My drug of choice for this one, let me scroll down, is theophylline. It's my most commonly used xanthine derivatives, but it's not used as often as our former ones. It can be obtained via rectal, oral, or injectable. or topical forms. It is a great bronchial dilator that we use to treat for bronchial constriction. If I need to use it IV wise, it would be, we call it aminophylline, which is a proform of that theophylline. To note is my level that we want to keep my patient in between 5 to 15 micrograms, per milliliter. So we have to do frequent blood draws to monitor my level of that medication. My next group are my non-bronchial dilating respiratory drugs. On my non-bronchial bronchodilating respiratory drugs, they work more to decrease some of the asthmatic symptoms by reducing inflammation, and they can also prevent some of the smooth muscle contraction of the bronchial airways, although they don't necessarily cause dilation. They do decrease some mucus secretion, which is going to help with that being able to breathe there. Let's see. These drugs are indicated for prophylaxis and long-term treatment of the prevention of asthma. They're used once daily dosing. Improvements are usually seen within a week of taking this medication, and they are not used for acute asthmatic attacks. My contraindication would be drug allergies, and the most common adverse effects of my LTRAs are headache, nausea, dizziness, and insomnia. So keep that in mind with that. It can also cause some serious mood-related changes or behavior. So if they note that, they need to notify their healthcare provider immediately for that. Table 37.4, let me scroll to that, has some interactions to note with our LTRAs. My drug of choice for this one is my montelukast. On my montelukast, it's a LTRA. It works by blocking those receptors to decrease the inflammatory response. The benefit of this drug is it's been approved for kids up to under 2, but over the age of 1 year of age. So that's a benefit, because earlier we mentioned that there aren't many things for kids under the age of 2. So this one's okay for kids over the age of 2. We have one more here. Our corticosteroids, and we mentioned steroids in a few chapters ago. Our corticosteroids reduce that inflammation. So they reduce the inflammation. So it has to get down to that area that's inflamed, which is why we typically use it in conjunction with a bronchodilator. We usually use these in an inhaled format, and they are very effective for treating bronchial spasms and inflammatory responses. We will very frequently use these in conjunction with other medications, such as our bronchodilators. They do have some adverse effects. One of the main ones I want to point out to you is the need to have patients rinse their mouth after using any inhaled corticosteroid, because it can cause oral fungal infections if we don't encourage that. There are some drug interactions that are also noted with these medications, especially if my patient's using phenytoin or phenobarbital. So keep those in mind. We also have an increased risk of hypokalemia if we use them with furosemide, such as our Lasix we talked about in our diuretic group. We have 2 drugs here. Go down to that. On my drug here, no, just one. On my drug here, my fluticasone propionate. It's administered intranasally or by oral inhalation. It's available in a combination form with a bronchodilator often. So we want to make sure we're teaching to use the bronchodilator first, and then the corticosteroid, and then to make sure they rinse their mouth out after that. Going to the end of the chapter, when we're assessing our patient with these, know what we're giving these medications for. Usually it's for that bronchodilation. So with that bronchodilation, we want to assess what all is going on with that individual. If they have bronchodilation, you're going to see some bronchoconstriction, you're going to see some anxious patients, which usually means everything goes up on them. Heart rate goes up, respiratory rate goes up until we can get that under control. And then notice in our interventions or implementation what we need to teach that individual when they're taking these medications. Think about preventing that fungal infection. So